Welcome to a new episode of Dysphagia Matters. We've got a pretty big group today, at least by our standards. But Julia, that's on you.
Yeah, so at this year's Dysphagia Research Society conference in beautiful Puerto Rico, I attended the session with Debra Suiter, Giselle Carnaby, and Martin Brodsky. And they talked about their goal to develop a unified definition of dysphagia so that we can all talk about the same thing that we see, diagnose, and treat in our clinical practice.
Yeah, so 3 years ago, we started this podcast discussing swallowing and swallowing disorders and the research in our field, but we never talked about what dysphagia actually is.
So we thought it's about time that we learn a bit more about what researchers, clinicians, and people with dysphagia understand by the term dysphagia.
So in this episode, we had the pleasure to talk to Debra, Giselle, and Marty. They explain why a unified definition of dysphagia is important, how researchers currently define dysphagia in their studies, and how they try to find consensus with key stakeholders on a unified definition.
But before you hear Debra, Giselle, and Marty talk about this topic, we would like to share this song with you. The lyrics were written by a person living with dysphagia, describing what it means to have dysphagia. And it was published by the NFOSD, so the National Foundation of Swallowing Disorders.
There ain't no easy way out. It won't go down. It won't go down. There ain't no easy way out. It won't go down. It won't go down. I keep hearing it down. It won't go down. I keep on swishing it around. It won't go down. I even think it might appear. But it won't go, it won't go, it won't.
You can listen to the full song at the end of this episode. Hello and welcome, Debra, Giselle, and Marty. It's the first time that we have actually 3 experts as our guests here, so we're really excited to talk to you all today.
So that our listeners know who is who, could each of you briefly introduce yourselves? Maybe Giselle, do you want to start?
Sure. My name is Giselle Carnaby. I am a professor and director of the PhD in Health Sciences at the University of Texas, San Antonio Health Science Center.
My name's Debra Suiter. I'm the director of the Voice and Swallow Clinic at the University of Kentucky, and I do a little bit of clinical work and research work as well here.
And I'm Marty Brodsky. I'm a section head for speech pathology at the Cleveland Clinic main campus in Cleveland, Ohio. And I guess everybody else said that they do research in clinic, and so do I.
Excellent. Yeah, thanks so much for taking the time. So to begin with, Debra, what initially motivated you to develop a universal definition of dysphagia?
Well, I think what motivated us was actually Marty and I have been talking about this for years, and then Giselle certainly came along. We brought her in because of her research expertise and the fact that she also had interest in this topic area. But kind of what we started talking about was in the context of screening, actually, because a lot of my work is focused on screening, and we had talked about what screening is identifying. Is it just aspiration or is it dysphagia, which then led us down the road of really what is dysphagia. And so I think we all were coming at it from the perspective that this was a physiologic condition and thought that that's how most speech pathologists looked at it. And then we started talking to other speech pathologists and realizing that we really are all kind of looking at this thing that we're treating and assessing in very different ways. And so started having the conversation about, is it patient complaint? Is it patient perspective? Or is it truly physiological? Or is it some combination thereof? And so then we decided that maybe we needed to investigate this a little bit further and started looking at the literature and realizing, again, that really as a field, we're all over the place. And we need to be talking the same language because it's to the benefit of our patients that we understand what we're assessing and treating. It's to the benefit of third-party payers. It's to the benefit of researchers that we all at least have some common ground from which we are starting.
And Marty, how did you do that? Which steps did you undertake to find this definition and to find consensus that everyone is agreeing going along with this definition?
It's kind of funny you mentioned that because the way we started it was definitely not the way we ended up. We took many of the quote unquote big names in swallowing, Logeman, Robbins, Langmore, and so forth. Okay, many of the big names, perhaps 20 or 25 of them. And we pulled a number of their publications. And it was all done on an Excel spreadsheet with students and with us contributing to that spreadsheet. In the might have been 50 articles thereabouts, we found what we thought were upwards of 300 definitions of swallowing. And rarely were they the same. Many overlapped, and many were out in the ether somewhere where we weren't sure why in the world somebody would define dysphagia that way. So that led to Deb and I kind of looking at each other like, this is a mess. What do we do with this? And I think that's about where Giselle came into the picture. And we said, all right, we have a problem here. Wrap our heads around this and let's figure this out, because neither Deb nor I have the qualitative skills that Giselle has. We have the quantitative skills that we can certainly complement Giselle, but neither of us were trained in qualitative analysis. And that's where Giselle came in, and she helped guide us down this really windy, twisty, turny path. And I'll just hand it over to Giselle to kind of complete the story here, because I got nothing else.
That's not true. So yes, that is where I came in. I had been aware of what these guys were doing. We talked about it. But in terms of putting a structure to starting this line of inquiry, we began with a qualitative scoping review, which is not a common thing in the literature in our base, and yet it is in public health. So it's following through with a line of inquiry called narrative analysis. It's a form of qualitative review. And what we did is we took a grounded theory approach to a narrative analysis, taking texts, just like in a normal scoping review, from all over, following a specific inclusion criteria. And we evaluate the text for the richness and deepness of definition. So with the help of our AI friends in qualitative analysis and through our team doing reductive coding, we were able to come to what we call saturation on different codes to look at how people conceptualize and define this particular issue differently. And in analyzing that data, we took multiple different reviews of it. We looked at it from a diagnosis level. We looked at it from a country, a professional level, a journal level. So there were different aspects of analysis that we went back and looked at the data at, so that we could get a broader picture of where the agreements and disagreements were and the kind of chaos that we were actually working in. And believe me, it was chaos. There were over 600 separate codes that arose from just the qualitative side of this. And then we ran a network analysis, which is another form of qualitative evaluation, to see how all those different codes connect. And it looks like spaghetti thrown against the wall as a diagrammatic presentation. And so we were then somewhat empowered to make the statement that we don't all agree. There isn't a defined agreed definition, which we weren't even sure at that time was the case. So when you have equipoise in any area of research, you have to find information that either supports or refutes your claim. And so we had now some data that supported the claim that this is a situation that's going to lead to inequity and difficulty in communication, and difficulty for us in the US in funding, even in getting paid for what we do, because we don't all agree with what we're actually measuring or what we're actually talking about. So following the qualitative scope review, we decided to then flip the coin and find out quantitatively if the stronger work in the area, and we only took one area, we took screening to begin with, although we identified 5 core different areas. We took screening and we wanted to know, well, do the more quantitatively robust and rigorous investigations do a better job of defining dysphagia? And is there more agreement amongst them? And that was Marty's role. So I'm going to throw it back to Marty.
So basically, we started out with almost 1,700 articles that were pulled by a couple of medical librarians at Johns Hopkins University with me when I was there. And in doing so, From those nearly 1,700 articles, we split those double blind within our team such that everybody was looking at exactly the same thing. We did training, we did reliability, all of that in order to make sure that we were all screening these articles the same way. In the end, we ended up pulling 350 articles that we had full text review on. And that means that 350 articles were effectively 350 PDFs that came into our hands, and we reviewed by hand, looking at every single article to make sure that we should or should not include it. In the end, there were 287 studies that entered into the analyses.
So everyone who has ever done a review knows how much work this is already.
It was a tremendous amount of work, and this took many months, as you can imagine.
Yeah.
In the end, we were looking for what went into these articles as definitions. I think Giselle can talk about that a little bit better.
When you run a qualitative analysis like we did to begin with, in this day and age, you use an AI bot with natural language processing capabilities to assist you because of the sheer volume of information. So we were looking at over 1,500 text snippets that were removed from each article, and that generated definitions with the assistance of the AI, and then with cleaning and revising and generative coding from a human as well. And then peer debriefing and member checking back to our group to confirm a set of selective codes. So this is like 16 different selected codes that coalesced in the literature we reviewed. Things like an aspiration-based definition versus a muscular definition versus a generalized statement like swallowing problem, or a PRO-based definition like an eat 10 lower than 3. These were the variable types of definitions you would find in the literature. And every study had more than one definition, and it wasn't the same, even within the papers. So I think it was way over 2 point something was the average definition per paper, but it went as high as 6 and 7 different definitions in a single paper. And so one of the things we actually found is, in fact, that the E10 was one of the most common definitions, whether you agree with it or not. One of the most common definitions that we had, along with just a general statement of a problem swallowing.
So if they've used the definition based on the E10, this means that if they were kind of abnormal, or if they had some difficulties with swallowing identified by the E10, then this was kind of defined as dysphagia.
Correct.
Is that correct? Okay.
Correct. And there were 2 different equally disagreeing ways of interpreting the E10 as well. So it's E10 general overall score and E10 less than 3. So you saw both of those definitions equally represented. So there's no clarity on what, if you're going to use that as your measure of dysphagia, as your definition of dysphagia, there's no clarity on even which one of those you use. So we still have equipoise here in finding a definition, but what we realized very quickly was there were multiple different definitions. And remember, that could be in one paper, but then they could have 3 more definitions in the paper that were equally different.
So not even like research.
They don't even agree with themselves.
Yeah. Well, that's not really helpful.
No. So we looked to see if maybe some countries were better than others, and we broke it down by country. And we didn't get any love from that when we looked at the country graphs, and we looked at the distribution of different dysphagia definition codes by country. They were vastly different depending on the country you came from. Likewise, in terms of the health specialty you might have been from. So we broke it down by where you practice with your ENT, gerontology, neuroscience, and again, vastly different definitions used even within health specialties. So yeah, in the final analysis is the network analysis to say, well, how are these things related? And as I described before, spaghetti thrown against the wall, everything was connected in various different ways, multiple different definitions, and no true agreement or coalescing across any set of definitions in any of the literature.
So in other words, nothing made really any sense.
We need consensus. It basically shouted that our whole purpose for writing this grant, for doing these conferences, for trying to tackle this issue is validated from the literature, from our own literature across specialties.
So this really highlights already the huge amount of work that you've done just as a kind of pre-stage, quote unquote, before you actually started trying to find consensus. So how did you do this? And did you actually find consensus?
Oh, Deb,
probably the most important question.
So essentially, we were funded through NIA, National Institute on Aging, it was a conference grant. So we've held 2 conferences, the first of which we held here in Lexington, where we invited roughly 33 people with expertise in dysphagia across multiple disciplines. So we had ear, nose, and throat physicians, we had critical care, we had speech pathologists, of course, dietitians, really trying to make sure that we had an adequate representation, at least from a healthcare perspective, to have a vested interest in the topic of dysphagia. And so we met here in Lexington, we held focus groups, presented the results of the qualitative, quantitative analysis that we had done, or at least to that point, what we had done, and then started looking at how we define this thing that we call dysphagia across the 5 different domains that we'd identified. So Giselle had mentioned screening because that's where we started with the qualitative analysis, but we've also looked at assessment, treatment, caregiver, and quality of life, I believe, are our 5 different domains. And so held those focus groups. We had a keynote speaker who is a gerontologist here at UK that really helped us in terms of looking at developing a framework from which we could start to approach trying to define dysphagia. And basically at the conclusion of that first year conference, we came up with a proposed framework, at least. And then as you've heard, we spent a lot of time doing the qualitative, quantitative analysis of the literature as it pertains to screening. And then this past year, we had a conference that was open to the public, and we really wanted anyone with an interest in dysphagia, including clinicians, including third-party payers, including patients. It really was open to anyone. And we started from the framework by introducing the framework. We did have didactic sessions as well, but we then presented the framework that we had developed at last year's conference and completed a Delphi process, but to try to come up with consensus. But we realized the first thing we need to do is make sure we're all approaching this and have an agreed upon framework, which we spent a great deal of our morning on Sunday morning debating that. Essentially 3 to 4 hours going back and forth in terms of what that framework was going to look like. And at the conclusion of the conference, I think we at least now have an agreed upon framework, but we still are a long way from that consensus definition for dysphagia. We still have a whole lot more work ahead of us.
And in some regards, we were quite naive in thinking that we would move to a consensus quickly, especially given the amount of disagreement and how many different definitions were being thrown around out there. Really, the best thing that came out of this follow-up conference, I think, was we've received a mandate from the professions that this needs to be done. And they're on board, they're interested, and we're going to move forward from here to have various different groups working on aspects of this to try and flesh out that, if you like, preliminary framework that has come out of this second conference. What was decided upon at the meeting was that it should be a categorical, almost like a staging categorical system. So much like they use in head and neck cancer with a TNM staging, a similar staging, the components of which have not been defined, and that's why we need continued working groups to try and flesh out some of that, along with another round of evaluation in different domains to support the content of those categorizations, if that makes sense. That's as far as we got. We got a mandate to create a categorical framework, like a staging model for dysphagia that can be used nationally and internationally, and it can drive payers so that once you move in, this gets complicated, but in the United States, the code for dysphagia at the moment is what we call an R code, which means that it's simply a symptom. And because it's a symptom, it's of lower value. What we need to do, and I think what we got from our group consensus, was the urgency and support to move it from a symptom status to a diagnostic status. And in order to do that, it gains significance across and between different specialty groups and different disease models. And if we're able to do that and then categorize the way we get to that, so we're not going to throw away the symptom, because for some presentations that simply will still fit. But to have another category where we're able to say, this is in fact a diagnosis, this therefore has higher importance, and then will attract for us in the US a stronger funding model to drive research, to drive efforts with patients, and to drive clinical revenue and clinical activities.
Yeah, so it's really impressive, even though you've done so much work and maybe you were anticipating to be at a different stage by now. It's really impressive how enthusiastic and optimistic you still are. So I'm really delighted to hear that. Do you believe that, because you've just mentioned great examples, how this is going to change probably clinical practice, research, funding, etc. in the US?
Everything.
Do you also believe that this definition has the potential for global applicability? So
Correct.
do you consider regional or cultural variations in understanding dysphagia?
So at this point in time, that is yet to be decided. What we believe is we're going to start with the US because that's where we're at. We did have international contributors to this. The data analysis that we've done that shows the chaos out there includes all different countries. So we know it's not unique to the US alone. I think it's very much, if you set up a really cogent, rigorous categorization system that allows flexibility from regional, we were talking about urban versus rural, regional versus national. If you provide a categorization system that can encompass that, much like they do with the NCI gradings, yes, I think it will be adopted. But it will throw the door open for different countries to then take this framework and see if it works for them. We won't own it.
It's a lot easier to amend it than starting from scratch, I guess.
Exactly. And we're not looking to own it. We're looking to find something that works for us. And I think if you look across different professions who've tried to do this, for example, the person who guided us here, Dr. Jika, he was intimately involved in the development of the coding that identifies dementia from mild cognitive impairment. And it's a very similar process that they've been through. And that coding has actually been adopted in numerous countries now, even though it originated out of the United States. So I think, we've got a lot of work to do yet. I can't say definitively anything, but I can say that this is probably a generational inquiry in this country and in others.
And I was also wondering, you've touched it in another topic with the dementia or mild cognitive impairment a little bit to differentiate these, because for once, of course, it's very important to know what dysphagia is in itself. But do you also think that it could help differentiate other disorders or signs and symptoms maybe? Because I was just thinking that in recent years, many people in the scientific community have discussed about presbyphagia, and is it something pathological or is it just the normal development of the swallowing due to age? And where's that cutoff between that's just normal physiology and now something pathological that we should treat? Do you think the definition of dysphagia could also help differentiate between presbyphagia and dysphagia?
Well, you think about it. If we don't know what the core basis is, how can we really be clear on any derivatives? And presbyphagia is a derivative. It's not, it comes out of the core. So I want you to think of this like Latin. Okay, so we need to identify the core and get the core solidified. And then, yes, it will have kick on to those different derivatives. If anything, it may enlighten and delineate those derivatives in a much more cogent way than we currently do.
If you think about it, as we develop this model or this modeling, it's not necessarily a model, everything comes from it, right? The way we teach our students, the way we teach clinicians, the way we get reimbursed from whether it's third-party payers or government entities, whatever that may be, the way we proceed with research, the way we get funded, all of this comes from, as Giselle said, the core. How is it that we have agreed to define dysphagia, and everything stems from there?
It even gets so large if you really think about it, and you think about the medical models that have arisen, right? So if you go back years and years ago, there was no such field as gerontology. So it could even lead to a specialized field development once you've identified the core, and it moves beyond just a symptom of other things to a true disorder in its own right.
There is a certain sector of the groups that we work with referring to themselves as deglutologists, right? This is not something that, for example, exists and is endorsed by the American Medical Association, but they may be onto something in terms of truly identifying the disorder and then pushing it from that standpoint. We're coming from a different standpoint, but probably to the same end. And that is recognition for what we do, the specialty that we have, the things that go into it, the intricacies associated with it, and the healthcare endpoints that can result when neglected.
And I would add the multidisciplinary basis of this.
Yeah, very important. Thank you. That's, I think, exciting. The point that we are right now, and we're looking forward to what is going to happen with your project and what you're going to find out. So if you could leave our listeners with one key message from your project so far, what would it be?
More to come.
And we'll talk to you again maybe in 1 or 2 years.
That might be a good time frame.
Yeah, excellent. Thank you so much for taking the time, for sharing your knowledge, your experience, and shedding light on how research works and how much work it is, but how rewarding it is. So yeah, thank you so much.
Thank you.
You're very welcome. Thank you for giving us the opportunity to join you today.
Well, it won't go down. No, it won't go down. I can try my best, I can move it all around, but it won't go down. No, I've tried my best just to make it go down. I puree all day till it's nasty and gray, but it won't go down. And it won't go down. It won't go down. There ain't no easy way out. It won't go down. Hey, it'll just stick around, and it won't go down. Well, I know what's right, I got just one life. In a world that just keeps spinning on around, but it won't go down. I keep puring it down, it won't go down. I keep on swishing it around, it won't go down. I even think it might fear, but it won't go down. Hey, baby, I ain't about to give up. Try every trick in the book. I won't be scared to eat out. Hey, I will stand my ground, and I won't lay down, but it won't go down. There ain't no easy way out. It won't go down. It won't go down. There ain't no easy way out. It won't go down. It won't go down. I keep puring it down. It won't go down. I keep on swishing it around. It won't go down. I even think it might appear, but it won't go down. Hey, baby, I ain't about to give up. right. I got just one life, in a world that just keeps spinning on around, but it won't go down.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.